Dr. Riley, did you send that communication to just Dr. Berger?
I sent it out.
You did?
I sent it to Pat Roblin to dispense to the COVID vaccine task force.
Yeah, I sent it like just before I got on.
Okay, I just haven't gotten it yet. That's all.
All right, you were ready? All right, good afternoon, Downstate. This is Dr. Wayne Riley. Thanks for joining us. I've called a live town hall meeting to discuss the first of at least 2 vaccines that will be approved within the next 30 to 45 days to address COVID. I know many of you have a lot of questions, so I'm glad that you're tuning in. We'll try to get to as many questions as you can. As you see, we have Dr. Berger, our CEO of University Hospital, Ms. Winston, our Senior Vice President, COO of the hospital, and Dr. Michael Augenbraun, our Chief of Infectious Disease at Downstate and at UHB. So hopefully between the 4 of us, we'll be able to address all your questions. Let me just first off saying thank you for what you've been doing over the last 9 months. It is hard to believe that we started with this just shortly after the beginning of 2020. And in fact, I was thinking about today on January 21st, I was in a meeting with other healthcare executives, and little did we know that that very day while we were meeting, MLK weekend, in fact, that was the first case reported in Washington State. And here we are on December 14th with the widespread over 15, 16 million cases, almost 300,000 or growing deaths. So no, we're the country's still in a world of hurt. New York, by comparison, is doing a little bit better, but we have issues here in New York as well. So in the spirit of transparency, that's why we wanted to have this meeting about the first vaccine. I can tell you that we will get our shipment tomorrow of the vaccine. We don't know how many doses we'll get. We suspect it'll be around 1,000 doses, roughly. And those 1,000 doses will be for the first administration of the Pfizer BioNTech vaccine that was just approved by emergency use authorization last Thursday by the expert panel. Couple things personally. I've looked at the data, colleagues. This is a very good vaccine. And this, as a physician, I can tell you that there's not much with this strong a data that we get to see and bring hope to not only just people here in the United States, but around the world. And I wanted to have this town hall to specifically address any concerns you have. I can clearly tell you that having looked at the data, this vaccine works in those of us who are Black or brown. It works in those of us over 55. It works in those of us who may be obese. It works in those who may have pre-existing conditions. And in the trial, the clinical trial that was run over the last 6 months, there were no deaths. So in other words, the way this trial was constructed is a classic randomized controlled clinical trial with designated endpoints. There were about 18,000 people who got the vaccine, 18,000 who got placebo. And out of the folks who got the vaccine, I believe there were only 8 cases of COVID. Whereas in the group, the 18,000 who got the vaccine, there were almost 200 cases of COVID. So when you do the statistical manipulation that they teach us in school, that extrapolates into a very effective vaccine. The side effects are what we expect with any vaccine. Your arm may be a little sore, you may have a little runny nose. The next day you may run a little low-grade fever, you may feel blah, you need to stay home, sleep it off. That is perfectly appropriate. That means your immune system is working properly and that your immune system is revving up to remember this should it be foisted upon you at another time. I have taken many vaccines in my life, as all of us on this conference will tell you. And, you know, this one I have no concern about. I have none. And look, there is always a risk and reward for everything in life. Nothing is 100%. Nothing is 100% in medicine and science. You can have an allergic reaction to an aspirin, colleagues. So, you know, I'm particularly concerned about what I'm hearing from Dr. Berger and Ms. Winston, that there's many of you who take care of patients who don't want to take this vaccine. I don't mind telling you as a physician, I think that's a mistake. You have to take this machine and consider taking this machine, first of all, to protect yourself, but also to protect your loved ones. Because as long as you're coming to work taking care of patients over the next 3 to 4 months to 6 months, you remain at high risk, or at some risk rather, of getting COVID. Or if you're going to personal gatherings over the holidays, you'll have some risk of getting COVID from, you know, home gatherings. So again, you know, I have no hesitancy taking this vaccine. And when Dr. Berger tells me that it's my time to get the vaccine, I will do it. But I will not do it before I think those of you who are more clinically active need to do so. And those are people in the emergency room, in the ICUs, in the clinics, whether you're at Kings County or UHB or the VA or any other place where we see patients, Brookdale. You know, those of you who put yourselves in front of patients every day, all day long, are the ones who need to get this first batch of vaccine. Now, like I said, we have the Pfizer vaccine today. By next Tuesday, we'll probably have the Moderna vaccine. It's very similar to the Pfizer vaccine. It will require 2 doses as well. And so one of the questions I know you're going to ask me, and Dr. Augenbraun and Dr. Berger and Ms. Winston, what's the difference between Pfizer and the Moderna vaccine? Well, they're both made by the same technology, using mRNA technology. And without getting too wonky, you know, you can think of it, these 2 vaccines, as Coke and Pepsi. You will not get a choice right away. We're going to give you, because all we've been given is the Pfizer. Next week, we'll have the Moderna. Possibly a month or 2 after that, we may have the AstraZeneca. By May or June, we may have the Johnson & Johnson. So my counsel to you is don't wait around for one particular vaccine. Take the one that we can give you the quickest, because that's the best way that we can get you know, the vaccine out to our community. So with that, let me turn it over to my right, Dr. Augenbraun, for his opening remarks, and then to Ms. Winston, then to Dr. Berger, and then we'll take questions. Dr. Augenbraun.
Thank you, Dr. Riley. I echo your sentiments about this vaccine. I understand people's apprehension about vaccines, and it's something that we struggle with on a regular basis. And this is a new vaccine. And I think it's a reflection also of rapidly changing technologies that all of us in science and medicine have to take account of. I mean, I think that this platform is going to be a platform for vaccines and other therapeutics for years to come. And it's a major, major improvement on previously devised platforms. From the data that Dr. Riley described, the safety is quite good. And the efficacy is astounding. There are some issues we don't know about this. We don't know how long the duration of efficacy will last. That'll be something that we'll have to wait to see. But in the short term, at least, it clearly works in excess of any effective vaccine that we have out there on the market. And given the epidemiology currently of COVID cases, those of you working in the clinical setting know that the case rates are rising in our neighborhood right now. This is the business. We don't have really effective therapies, but we have an effective vaccines, and pound for pound, vaccines are some of the most effective interventions that we can make use of. So I would also encourage everybody to take advantage of this opportunity if they're on the list that we have thus far. So those are my comments.
Great. Thank you, Dr. Augenbraun.
Sure.
Ms. Winston.
So I encourage people to consider taking the vaccine. I know many of you, not many, some of you have said that you're not interested. You can change your mind. We're collecting this list because it's important for us to get started to be able to administer the vaccine. They're giving us an allotment of doses per week. If we don't give them, then we don't get the next week's supply of vaccine. So please consider it. We will be sending information out to you, facts to you, for you to consider. We're putting together information for our patients to understand so that they can consider. And I know we've had a tough time with vaccines, but it's really important for you to consider this. Consider all the pieces. There have been a team working around the clock for the last couple weeks, trying to put together a program and a plan that's easy for you. Some of you may schedule yourselves, and others will be scheduled by supervisors once you say yes. So we want you to stay tuned and hear, and just please consider taking this vaccine. That's all I have.
Dr. Berger?
So good afternoon. Thanks, President Riley. I appreciate the opportunity to talk to the community this afternoon. And I want to thank Dr. Riley for putting the trust in me to help manage the delivery of vaccine to our workforce and to our students as well. So I had the opportunity to walk around the hospital today, including walking around on our COVID designated unit, Nursing Station 62, and talk to people about the vaccine. And there's two concerns that have been voiced. One is that this vaccine is new, and secondly, that the vaccine has been rushed. Well, for the first, I want to comment on the fact that the vaccine is new. So the vaccine is new. However, this technology has been used 3 to 4 years ago to develop vaccines against SARS. For the first time, we had a major respiratory disease caused by a similar coronavirus. And that vaccine proved to be very effective against SARS. SARS petered out sort of on its own, but the technology is exactly the same as was used to combat SARS and develop a vaccine against SARS. So that's the first thing. So it's not completely new, although this specific vaccine is new. Secondly, the comment about it being rushed. Well, it is a miracle of science that we identified a new disease a year ago, and within a year, we have an effective vaccine. I don't think anyone could have predicted we have a vaccine that's over 95% effective. And in fact, we have 2 vaccines that are over 95% effective. These vaccines have been vetted by multiple agencies. They've been vetted by the equivalent of the FDA in Europe, in England, as well as the FDA in this country. And the FDA took this very, very seriously because of the fact that it was developed so quickly. So this vaccine has gotten an amazing amount of scrutiny. Yes, it came across and got developed and it's come to market very quickly, but the scrutiny has been intense, and therefore I have the utmost confidence that this is an effective vaccine. Now, we are all tired of talking about and dealing with COVID. I think there is COVID fatigue everywhere. Our caregivers are tired of taking care of the patients. We're tired of the limitations on our lifestyles because of COVID. We're tired of the devastation in terms of the economy. We are tired of this disease. The only way forward, and the only way we're going to eradicate this disease at this point in time, is to vaccinate a significant portion of the population. That's the only way forward. And I think going into 2021, talking to people in the hospital, outside the hospital, everyone wants to turn the page on 2020, and that's because they want to see COVID gone. So please, please consider getting vaccinated. We need to do this for our patients, our families, and ourselves. And it's really, at this point, the only way I can see forward to get past this pandemic. So thank you.
Great. Thank you, Dr. Berger, Ms. Winston, and again, Dr. Augenbrand, for your opening remarks, and thanks for all you do on a daily basis to help our patients. There's some way we're supposed to be getting questions. I don't see them, but we'll just rattle off a few of the common questions that we've been hearing. One of the things I've been hearing is, particularly in African-American communities, is the whole issue of, the Tuskegee syphilis experiment and some of the other things that have happened to African-Americans historically vis-a-vis the healthcare system. Let me make sure we understand what happened at Tuskegee, because this is nowhere near, excuse me, what happened at Tuskegee. The Tuskegee syphilis experiment started in around the mid-1930s in rural Alabama. During that time in the rural South, syphilis was sort of a pandemic of syphilis in the rural African American communities of Macon County, Alabama, which is near Tuskegee. And the U.S. Public Health Service, after sort of looking at another study that had been done in Oslo, in Europe, they looked at syphilis in Europeans, in Norwegians, in fact. They said, hey, let's do this here in the United States. And a little unknown piece of history here is they got advice from the then New York State Commissioner of Health to say, hey, you guys ought to do this study to check the natural history of syphilis down south. Well, the U.S. Public Health Service, which is an agency of the United States government, went around testing Black men, most of them illiterate, most of them rural. And when they found positive cases of syphilis, they did not give people syphilis. But when they found a gentleman, mostly men, I think it was 699 men, they enrolled them in this study. And what they did is they brought them in every 6 months or every year. They'd give them a physical examination. They'd give them a free meal. They'd, drive them to the clinic at Tuskegee. They would draw their blood, and they never really quite told the men, you have syphilis. They kept, in some respects, they referred to it as you have bad blood, so we need to check you periodically. And so they kept following them. So take the 30s into the 40s. By the late 40s, correct me if I'm wrong, Dr. Augenbrand, but penicillin was approved as the definitive treatment for syphilis in like 1949 or so, but they didn't stop the study at that point. The ethical thing would have been to give the men who had been told that they just had bad blood but really had syphilis, give them the definitive treatment in the 1950 time period. They didn't do that. The study kept going up until 1972. And again, that is the reason now why we have such things as institutional review boards. We have all the regulatory overlay that anybody in the United States and indeed the world now has to do in terms of human subjects, working on conducting research on human subjects. So sometimes people don't understand that the United States government didn't give the men syphilis. They just didn't treat the men syphilis. And the other thing, quite frankly, for those of us who are African American, there were Black physicians who were part of the Tuskegee syphilis study. The main nurse who drew the blood of these men for over 40 years was a Black nurse. She knew that this was wrong at some point, but she kept doing it. So we have to understand we have a complicated history about Tuskegee. So again, this is nowhere near Tuskegee. This is a disease that is running through Black and brown communities, for which we now have a definitive vaccine, which we are now offering to Americans. Now, the unethical part would be if we knew this vaccine would work, and then we said, well, you Black folks can't get it, brown folks can't get it. That is not what's happening here. We know by the data, this thing works in Black and brown folks. And we can't draw a direct parallel to Tuskegee, which is one of the darkest episodes in human research ever. that the fact that these men were never told for 40 years that they had untreated syphilis. So again, history is important. We need to know our history, and that history is tough. But that history is illustrative of the fact that there was a cure for the disease these black men had, and they weren't offered it. In this case, there is a preventive in the form of a vaccine to prevent COVID that is killing people. So I want to be very clear about what the Tuskegee situation is. And again, the panel that approved this vaccine had at least 3 African-American physicians. The leading researcher in Dr. Fauci's lab who reviewed the data is an African-American woman, Dr. Kesmikia Corbett. He's told many of us in private sessions that, look, when Kesmikia tells me this is the good vaccine, I will take it, because he has that much faith in this talented African-American woman in his laboratory at the NIH. So again, we can have feelings, but this is different than the flu, colleagues. Many of you choose to not take the flu vaccine, which, by the way, I don't agree with you on. But COVID is killing people way more than the flu kills. And again, just every day you pick up the paper and some famous person is dying from COVID. Or more importantly, somebody in your life that has had COVID, or has a relative who's had COVID, or a significant other, spouse. It's estimated that 70% of African Americans that know at least one person in their life who had COVID. I had 2. My brother-in-law had COVID, recovered. I had a cousin who had COVID, thank God, recovered. But some of you have had relatives who did not recover and died from COVID. So why would you not consider a vaccine that could prevent you or your loved ones from dying? So let's go to the questions, because I wanted to get the Tuskegee thing understood. And Mike, you want to say anything more about Tuskegee?
No, I think you hit the nail on the head. I think that's unfortunately been a stumbling block and an understandable one for a lot of people to wrap their arms around legitimate medical interventions. And it's something we have to contend with. We have to always look at things in the context of that. But I think you really addressed the issues.
Great. Now there's a question here in chat. Is there somewhere where we can read about the study? Yes, the data have been published publicly on the FDA website. You can go to the data. It doesn't say Pfizer vaccine. What it says, let me tell you what it says, because the technical title for the vaccine is BNT16B2. And because remember, Pfizer is the manufacturer, but the laboratory designation. So, and then, for those of you who have access to New England Journal of Medicine, the New England Journal of Medicine published an abstract of the data last Thursday. So it's widely available. If you just Google, the Pfizer vaccine data, it will come up. There's tables, charts, numbers, everything. So the FDA has been incredibly transparent about the data. There's no secret data here. It'll tell you the number of African Americans in the study. And the study had about almost 9.8, almost 10% study participants. Well, you might say, wait, Riley, that sounds low. No, that's almost 3 times normal amount of African American study participants in clinical trials. We're lucky sometimes to get only 1.5 to 2% Black folks in clinical trials for anything. The fact that it got close to 10% is horrific. And you got to remember, we're 13% of the population. So if we could get close to our population in the United States, that makes it statistically, correct. In terms of Latinos, it's, I think, 28% Latino. So basically, this vaccine has been studied in participants that are 30% non-white. That is pretty darn good, colleagues. So we can't say it wasn't studied in us. It was studied in us. The second thing, Mike, they asked about, well, will there be another strain of this vaccine? So the same questioner asked about where can we look at the data, right? And they said, well, why should I take this vaccine if there's going to be another strain of COVID-19? Can you handle that one?
Yeah, I just echo what you said about looking at the New England Journal article, which could be intimidating for some folks, I imagine. The CDC is also a great site, for all sorts of information, and FAQs are, frequently asked questions about the vaccine. So I would refer people to the CDC website as well. My reading about this is that there's really not been a lot of variability in the strain of coronavirus circulating, such that we see a lot of changes in it. And, although there have been reports of people who've gotten reinfected, it's clear that that's not happening that much. So I think the bottom line is there's a lot of consistency. I think the problem with the durability of the vaccine is just what we sort of see with immunity to standard coronaviruses that circulate in the community all the time, the common cold viruses. We just don't make effective antibodies for long enough against this. And it's conceivable that we may discover that we need booster vaccines if this pathogen stays in the community long enough. But at least in the short term, this sure works. And that's really what we need. So,
right. In the short term, defined as 3 to 6, 3 to 9 months, maybe 3 to 12 months. Again, Pfizer does not stop studying this thing just because it got approved last Thursday. They're going to be following all almost 42,000 patients for the next 2 years. So their work doesn't stop, and they'll have to report to the FDA on a weekly, if not monthly basis about everybody who's been in this study in terms of what happens to them. So that's called post-marketing surveillance of any drug that the FDA approves. The second part of the question is, why is there such a strong push to take this vaccine when there was so much reluctance to test people back in March and April? Great question. It wasn't so much that there was a reluctance to test people. We were frustrated we couldn't test people enough because there wasn't enough test available. And in some respects, I don't think testing is still where it needs to be. So in March and April, I was fighting on a daily basis to get us supplies to test. We were running out of swabs one day. Next day, we don't have the medium. Next day, we didn't have this. We had shortage of lab techs to run the test. I would have tested everybody in Brooklyn if it were left to me, guys. But there wasn't enough testing available, and every state in the country was competing against every other state for testing machines, for testing supplies, for reagents, for swabs, name it. So it wasn't a reluctance. It was that we just didn't have enough testing capacity back in March and April. Our testing capacity is easier now, but I would still argue it's still not good enough. There needs to be a test where you could take it at home. A home test. You could take it 3 or 4 times a week if you want. That's the kind of testing that we need in December of 2020 that I think will make a difference into 2021.
There's some questions on the chat, Dr. Riley.
Yeah, I'm trying to get to it. Yeah, why don't you read off one, David, so I can't see it all.
So the first question is for residents and fellows that rotate through various hospitals as well as have different pay sources. Will they all be eligible to get the vaccine through downstate? So the simple answer is yes. What our affiliates have agreed to do for those people who do have pay sources through the county or through the VA is they have a vaccine available through those sources. But if it's easier for you to come to UHB, we will vaccinate our residents and fellows through UHB. So no resident or fellow should be denied a vaccination because of what their pay source or location is.
Correct. Yeah, let me just underscore that. I want all our residents to get this vaccine as well. You guys are even more online than some of us older doctors. So we want to protect you and your young families. So I urge you to get this vaccine. And as Dr. Berger said, we're committed to making sure you get it either at the VA or at Kings County or here on our campus. And we'll work out those logistics. The other thing, this vaccine is free. It is free for the American people. It's already been paid for. So there's no charge for this. We will not be charging any of you. I don't think your insurance companies will be charging as well either, because the United States government has paid for this vaccine.
We may collect insurance information because the vaccine portion is paid for, but the resources necessary to actually administer the vaccine are reimbursable both through the federal government as well as through private insurers. So we will potentially be collecting insurance information.
Right. And then again, that's another way that they will track how many people get the vaccine is by some of the insurance information. So you should have no worries about that in particular, because we're all state employees, very good health insurance. You know, we're very blessed in New York State to have one of the most generous health insurance programs of any country in the United States. So we have very good insurance.
There's another question through the chat. It was on the news that some people who have severe allergies get sick after taking the vaccine. I myself carry an EpiPen in case of an emergency. How safe is this vaccine really? So I think Dr. Riley commented that this vaccine is very safe. There have been a couple of episodes documented in patients with severe allergies who do have the requirement for carrying an EpiPen, that there could be an allergic reaction to this vaccine. If you do have that issue, I would suggest waiting till next week and getting the Moderna vaccine. That doesn't mean the Moderna vaccine is safer than the Pfizer vaccine. It just means in this one instance, they've seen less of these anaphylactic reactions to Moderna than to Pfizer if you have extreme allergies to either food or to medication. So I would advise waiting the 1 week and getting the Moderna vaccine.
Yeah, Dr. Argenbaum, you want to weigh in on that?
I agree with Dr. Berger. I might also add that it probably would be reasonable for any individual to have a discussion with their physician about that risk. That would be a discussion that would be worth having. I think people have one of my concerns is that people have a lot of concerns about allergies per se, and they're not always well-founded. Sometimes they are, and I'm just fearful that some allergy history may scare people away. I think what Dr. Berg is talking about are severe allergies. I don't want anybody with any, getting the message that any kind of allergy means you should be spooked by this. So.
No, not at all. It's not. You should not take this medicine if you just you have a little rash, no. I'm an internist, so I used to do this when I was a real doctor, as my wife said. Look, if you've ever been told by a physician you need to carry an EpiPen, or you've been given a prescription for an EpiPen, you never got it filled, you don't take this vaccine right now. But yeah, I'm allergic to, something. I'm allergic. No, that's fine. Because if you don't have an EpiPen or been told that you need an EpiPen, you should take this vaccine. But if you're in that group that has had severe allergic reactions requiring you to carry an EpiPen, or that you've been told you need an EpiPen, you didn't get it, because that happens a lot too, by the way. A lot of you have been told you need to carry an EpiPen, and you say, I'm not going to bother with that. Well, no, you shouldn't take this vaccine in particular. Wait till another version comes out. I see a question. Where do staff and outpatient clinics fall in the hierarchy? Who gets the vaccine first? So this is the other thing. It's not Riley, Berger, Winston, and Augenbraun determining who gets the pecking order. It's basically the governor and the Department of Health who have laid down some very strong guidance. So I'll have Dr. Berger go through what's considered tier 1 and then the other tiers. But no, we're following New York State guidelines on who should get in line first for this vaccine. So David, you want to talk about that?
Yeah, so thanks, Dr. Riley. And so New York State, New York City, both the Departments of Health have been very proscriptive about this, and certainly trying to be equitable in terms of who gets the vaccine. So the people who are in tier 1 are those people who work in the emergency department, who work in the ICUs, and who work in the acute care areas, the acute care floors where COVID patients are being housed. Those are everyone in those areas. So we're not just saying the physicians or the nurses, or we're excluding if there are police who are working in the ED, we're including everyone within those work units. So that's first. And then after that, it's other acute care areas that have exposures, such as the operating rooms, the endoscopic suites, other floors where patients may circulate that have COVID or may have COVID, or patients under investigation. And then we'll start circulating through the ambulatory areas. So the ambulatory areas and all the areas in the hospital, you have to realize anywhere there's a healthcare worker who has exposure, you're in the first wave of vaccination. And within that first wave, there's A, B, C, D, E, but you are still considered in that first wave. And we will try to get to everyone in the first 2 weeks who are anywhere in providing health care or in contact with the public and potentially at risk for COVID.
Right. Great point. So again, we're following the guidance. So my hope is that everybody who is patient facing in that whole scheme has been vaccinated by the end of January, no later. That's the end of it. Like I said, we're starting tomorrow, but it's going to take 1, 2, 3, 4 weeks to go down the list. And in that list, of course, we already said residents are in the higher part of that list. Also, medical students or nursing students, PA students, or we're doing clinical rotation. You will be offered the vaccine more towards the end of January, because we have to do all the other folks prior to that and based on the supply. But for the particularly 3rd and 4th year medical students, you will get this vaccine in no later than the end of January, if our supply is coming like the governor and the Department of Health is telling us. Great question. So again, somebody asked about minorities, and now the very ones who are being pushed to take the vaccine. As such, skepticism runs high among us. Well, that's why we're having this. We're having this because Dr. Berger, Ms. Winston, and Dr. Augenbraun are hearing from a lot of Black and Latino nurses and staff that they don't want to take this. And I will tell you, colleagues, as a physician, that is not what we should be doing right now. This thing is killing our people. And no, we need to take it. And I will take it at the front door of Lenox Avenue, Lenox Road, when Dr. Berger tells me I'm in my time in line. I'm not cutting in front of the line to get this vaccine. But for those of you who want to see Riley get the vaccine, I will take it in a place that's public where you can see me getting it, because I want to show to you that I'm not afraid of this vaccine. I want this vaccine for my 2 daughters, my wife, my mother, my brother, my sister. So the Riley family, when offered, will be taking this vaccine. And that's why I want you and your families, particularly you at this point, and ultimately your families, to get this vaccine. Because the only way we're going to get to this so that it stops being a threat to our community is that we get more and more people vaccinated. And I talked about Tuskegee earlier. We got to let go of Tuskegee on this. This has nothing to do with Tuskegee. This is about saving your life and the life of your loved ones. And somebody also said, why is the US president reluctant to get vaccinated? I'm long past my level of patience commenting upon the behavior of, the 45th president of the United States. I'm looking forward to the leadership of the 46th president of the United States. What are the ingredients in both vaccines? Let me let Dr. Augenbraun sort of break that down for you.
Well, I don't want to get into a lengthy discussion about the process of manufacturing the vaccine. I'm probably also not qualified to talk about it, but it's mRNA. You probably have heard those terms, and basically a lipid capsule, fats, so that the RNA itself is easily degraded in the body. And in order for the mRNA to reach its target inside the cell, for the manufacture of this material that becomes the stimulant for immunity, they have to wrap it up in these lipids or fats. And those are basically the components. The fats degrade, obviously, as they do elsewhere in the body. And the mRNA, after some time, also degrades in the body. But those are the primary components of this vaccine.
Right. And again, common things that all the medicines we all take are made of. Capsules, those little capsules of Tylenol. That's a gelatin, that has a little fat in it. So we take these things all the time for common things we all take, whether it's, allergy medicines, contraceptives, high blood pressure medications. These are all common manufacturing, materials that have been used to produce, this vaccine in more liquefied form, obviously, in molecular form.
I just might want to add, I think some people probably have hesitation about this because of the new technology of using mRNA. And I think you early on commented on the fact that it's been available. Dr. Berger mentioned this for a while, and it's being used in many trials, both for vaccines and for cancer therapies as well. Again, people are worried about this because it sounds like this sort of genetic manipulation, I think. And the fact of the matter is, again, mRNA of this nature degrades after a short period of time. The material doesn't get into the nucleus of anybody's cells. It doesn't hijack the operation of the cells. And it looks like in 10 years of experience and studies that this is actually quite safe and quite immunogenic. So people shouldn't be worried about this as a platform for creating new vaccines.
Not at all.
In fact, it's a better mousetrap, as they say, because it can be subjected to proper manufacturing procedures more easily than old vaccines. It's probably safer than old vaccines in many ways, and can be turned around on a dime, as Dr. Berger alluded to. It's rather remarkable that in the span of 9 months now, we have a vaccine that's this effective against the pathogen. It would take years to develop, years, maybe decades to develop on the old platforms, effective vaccines anywhere near this. So
exactly. And again, I think this new mRNA technology is going to open up a new vista of biomedical research for cancer, maybe for HIV. We've been chasing an HIV vaccine, for all of Dr. Augenbraun and Dr. Berger and Ms. Winston's professional life, and we don't have it yet. So that's how fortunate we are to have this. Next question is, where are the vaccinations being administered throughout the hospital? I'll have Dr. Berger and Ms. Winston tell you about that. And will it be mandatory for employees? So Pat, take that, but let me tell you about this. I don't have the authority to make it mandatory. But if I did, I would, but I don't. I'll be very blunt with you. I do not have the authority, but if the governor gave me the authority to do so, I would. That being said, the governor does not want to make it mandatory. He wants you to listen to the advice that I'm giving you, Ms. Winston's giving you, Dr. Berger's giving you, Dr. Augenbraun is giving you, Dr. Fauci is giving you. So he'd rather it be done that way. So I don't foresee a point where it's mandatory for state employees or for downstate employees. But let me tell you what will happen. Many of you travel back and forth to the Caribbean, whether it's Barbados or Trinidad or Puerto Rico, Dominican Republic. Guess what? It is highly likely that the airlines that you normally fly down on will require you to have that vaccine. International travel, if you expect to go visit your families internationally, I think it's perfectly plausible that international airlines will say, well, we're not going to let you on our plane unless you've had the shot. Now that may sound harsh, that may sound, but I can't blame them. I wouldn't let anybody on, on my airplane that didn't have the shot during this particular time. For those of you who have college-age students, colleges have perfect right to say you can't enroll in our school unless you have your shots. Once they have a shot for young children or for teenagers, now that may not happen till the end of next year or after that, but if you want to send your kid to a private school or a church-related school, they have the perfect right to say your kid can't come here unless your kid has this shot. So it's just like all the other things that they require so that, students don't get sick. College campuses, Mike will tell you, meningococcal disease, they require meningococcal vaccine. If you're going in the United States military, you don't have a choice about whether you take shots or not. When your son or daughter volunteers for the Army, Air Force, Marines, or whatever. If some of your kids play sports, they may say you can't play soccer unless you have the shot. So, there's only so many ways you can get around this, ladies and gentlemen, that even if I can't mandate it, your life will be very difficult if you don't get the shot. Ms. Winston, you want to talk about where you're going to administer it?
So we are going to be administering the vaccine in Sodexo Court. If any of you went through there lunchtime or went by there, you saw that the back areas that were designated for first our patients, our visitors, and the other side, which was for dietary, that's the area we're using to vaccinate you. There is a process that'll be in place for scheduling you. And as I said in the beginning, some of you will be scheduled if you have said yes, and some of you will be able to schedule yourselves. It's important for us to give these vaccines timely. When you go by there, please look and see the setup. We're going to have tables. We have you stay there for 30 minutes, which is part of the observation after you received the vaccine. So there are registrars, there are nurses, there's equipment. We are prepared to take care of you and to keep you comfortable until you can either leave or go back to work, which depending on the time you take the vaccine.
Pat, you want to talk about what they should do after they get the vaccine?
After you get the vaccine, we want you to, if you start to have symptoms, we want you to take care of yourselves. We're going to have a hotline where you can call if you think the symptoms are severe. That's being developed now. If they're not, you feel bad and you just, you have a low-grade fever, stay home, sleep it off. And then come back to work. But as they say, other than if they're very, very minor and you're fine, you can work. But we want to take care of you and have this hotline for you if you feel that you're having more severe symptoms.
Right. The other thing Dr. Berger will tell you, we're not going to say everybody in the emergency room get the shot on one particular day. It's going to be staggered. So just in case people do have any issues, the whole ER staff won't be knocked out. So Dr. Berger, you want to explain how you're doing that?
So we have a team that's looking at prioritizing everyone. And that's why Pat said some people will be scheduled versus others will be able to sign up on their own. The people who are being scheduled, we want to stagger the different units to make sure that we only do a certain number of people from each unit on each day so that we ensure that we have adequate workforce to take care of our patients. So that's really why the two different pathways for scheduling.
Right, I don't see this on campus. So remember, this is the first of two vaccines that we know of. And Mike, help me out. I know there's at least two others that are further along in clinical trials. One is the AstraZeneca, and the other is the Johnson & Johnson. Correct me if I'm wrong, but the AstraZeneca is both of those just one-dose shots?
Yeah.
Okay.
And they're different formats, if I'm not mistaken.
They're adenovirus. Yeah.
Yeah.
Yeah. So again, by July 4th, of next year, we will probably have at least, I would say at least 4, if not 5, vaccines widely available, not only in the United States, but around the world. And again, you know, we don't want people to wait, say, I'm going to wait.
Right, right.
No, you get the one you have now. Because the sooner you can become immune to it, the less risk you are to getting the disease during this cold winter months, and then going into the spring. So again, later on in the year, and by then we'll have even more data. We'll say, well, this particular vaccine maybe we'll use in teenagers, or this one we'll use in children. We won't know that for a little while. So that's why, remember, the Pfizer vaccine has only been FDA approved for emergency use authorization for 16 and up. And so everybody wants to know, what about, you know, the younger teenagers, the tweens, the 11, 12, 13s? Well, the good news is they've had less disease, but we still, at some point, want to get the shots into them as well. So again, this is part of the data that has to be generated, as Dr. Augenbrand will tell you, through further work. You want to talk about the children issue, Mike, a little bit?
I can't say I really have a lot of experience with the data in kids. I mean, the studies are ongoing now, so I think we just have to wait.
You just got to wait it out. So this one's 16 and above. Now, we don't have too many 16-year-old employees in the building, I don't think. If we do, we got a problem.
There's another question, Dr. Riley. If you have tested positive for COVID-19 in the past, does that affect your tier rating for when you get vaccinated? So the most recent recommendations are to wait 90 days after a COVID infection. We haven't seen any update on that. But if you've had it in the distant past, there's no issue in terms of your tier rating for when you do get vaccinated.
Is that right, Mike?
Yeah, there was originally discussions about limiting this and not allowing people who've had bona fide infections within 90 days before the receipt of vaccine to get the vaccine. Actually, in the package insert for the Pfizer vaccine, I didn't see this reiterated, so I'm not really sure where we stand on that. I will say that infections in the past, certainly beyond 90 days, is not an exclusionary criteria. You can conceivably get this again. Immunity wanes. And so I think people who had it in the spring should consider themselves eligible to get it now, get the vaccine now. I would encourage them to do so.
Right. So let me underscore that. If you had COVID, or you know someone who had COVID back in March, April, May, June, July, August, they still should get the vaccine. Now, if they had COVID last month, stay tuned. We'll have better idea in a couple of weeks as to whether that should be so. But if they had it, again, March, April, June, July, August, September, October, yes, they still should get the vaccine.
Dr. Riley, I'd like to make a comment. I'm on a chief nursing officer listserv around the country, and the conversations are following exactly what we've explained here. A third of the staff vaccinated at a time. People should rest. If they feel sick, stay home. It is not mandatory. Most of these hospitals are not making it mandatory now, but they are encouraging people to get the vaccine. So pretty much around the country, we're all treating it the same way.
Right. Now, just to fine tune on this, because I heard a labor lawyer talk about this. Remember, the FDA approved this for emergency use authorization. So sometime in the next months or year, it will be approved, fully approved. Once it's fully approved, then some employers, I'm not saying we will, or the state of New York, but some private employers will require you to do it. Now, I know some of you have second and third jobs at non-public institutions. So if you work, for example, you do a couple other shifts a week at, I won't pick on the specific name, but a private hospital in Manhattan, they can require you, as a condition of working there, even as a part-timer, that you have this vaccine when it's approved, fully approved. So again, it's going to be difficult to bob and weave around this because you won't be able to, travel will be difficult, et cetera. So that's what I said. It's better just to get it over with now and take the vaccine, colleague. Okay, it's 3:56. We wanted to limit this first one to an hour. We are all committed to doing this again. So you can answer because we'll let people go. It's almost 4 o'clock.
I just, if I could make one last comment, you know, sadly, you know, we lost a lot of colleagues back in the spring. And I only wish that we had the vaccine then. And I frankly don't want to have to live through that again. So, you know, we are all as vulnerable as our colleagues were at that time. So people should really reflect on that.
Right. Well, I can tell you, we lost Dr. Charlie Mahoney. If Charlie were sitting here today, he would tell you to take the vaccine because he was a man of science. He knew how bad this was for our community here in Brooklyn, and regrettably, he doesn't get the choice to take it. You do. And in his memory, I will implore you to get this vaccination. All right. Well, for those of you celebrating Hanukkah, happy Hanukkah. And again, we're happy to have another session either just before Christmas next week or the following week or just after. We'll do this as long as we need to. If we need to keep up these information sessions all the way into the summer, we will. It may not always be us four, it may be others doing it, but we are committed to making sure that we get all your questions answered to the best of our ability. We talk to the experts in Albany and in Washington and CDC and FDA frequently. So we're bringing you the best information we can, and we'll continue to do so. I will tell you, the governor has told us all that we're in for a rough ride over the next 90 days. He's particularly concerned about the last 2 weeks of January because we know that people are tired and they're letting their guard down and they're doing things that they should not be doing, such as having big gatherings. And that will fuel a big spread between January 15th and February. So we're going to brace ourselves for that. But we could blunt this by getting as many of you, vaccinated now, knowing that we're going to get slammed again in January because of the holidays. And that's yet another reason for those of you who take care of patients to get this vaccine, because we're going to get hammered again in January. And you would feel a whole lot better going home after your shift in January, after you've taken this vaccine over the next 2 weeks, knowing that you are much better protected. Remember, this vaccine is 95% effective in preventing COVID-19. So get ready for the end of January, colleagues. This is not over. You know, the governor has closed restaurants as of tonight. We could be entering another lockdown period in New York City. So again, that's yet another reason for you to get this vaccine while we have it, while we can do it quickly, and while we can do it efficiently, because we have to get prepared for the end of January. So this is going to be a tough winter, a tough holiday period. And again, please consider get this vaccine once it starts getting administered tomorrow. With that, I'll sign off. Have a good evening.